is my pleasure to introduce Dr. Davis, who is professor and chair of melanoma medical oncology. So he is my boss, and he is here not because of that, but because he's actually dedicated the vast majority of his career to studying brain metastases in melanoma, both clinically, leading even clinical trials that you hear about with targeted therapy for brain metastases. But his lab has really made some key discoveries in kind of how brain metastases work and how they could be curtailed, and has really informed researchers around the world how to kind of address the issue of brain metastases. So we're really happy to have Dr. Davis here today to talk to you about systemic therapy for brain metastases.
Great. Hussein, thank you so much for that introduction, and really welcome to everyone here. And I'd like to actually just do, again, a special thank you to AIM at Melanoma. You know, when we were talking to them about what to cover in today's meeting, we talked about the fact that brain metastasis is something that, you know, my patients often talk about, you know, is something that they're really afraid of. And it's something that I hear from a lot of practitioners about how to treat this. And, you know, one of the things that's been really remarkable is how we've developed so many new approaches, not just to treat metastatic melanoma, but specifically melanoma that's metastasized to the brain. And we're really entering a new era where I think we're so much more hopeful about the outcomes for our patients who are diagnosed with brain metastases. And again, hopefully can convey that to you, just how much progress has been made, but also where are there needs for further research and further progress. So with that, let me go ahead and share my screen. So my topic specifically, following up on the conversations about neurosurgery and radiation, is to talk about advances in systemic treatments for patients with melanoma brain metastases. And so, again, as Hussein mentioned, I do a lot of research, and so just want to go ahead and disclose that both in the laboratory setting and in the clinical research setting, I do work with a lot of companies. We'll say that this really is because we're trying to do our best to take the therapies that are existing or therapies that are being used in other cancers and asking very specifically how they can be used to help improve outcomes in patients with melanoma, and particularly patients with brain metastases. Now, historically, again, radiation and surgery have been sort of the linchpins of the treatments for patients with cancer that is spread to the brain. But there really is sort of an increasing both rationale and use of systemic therapy in these patients. And so again, surgery and radiation very directly take care of those tumors that we can see on our MRIs and our CT scans. And so sometimes the question is, well, what is the role of systemic therapy, which is being given to the entire body to help patients with brain metastases? And so there's actually a number of reasons why we think systemic therapy is an important component of the multidisciplinary management of cancer that is spread to the brain. So very first, as I'll show you, we know that these systemic treatments can treat the brain metastases that we're able to see on these MRI scans. However, we also know that in many patients, there's probably small collections of tumor cells that are too small for us to see. And again, radiation does a great job of focusing on the spot that we aim at to kill the tumor there, but it's not going to affect the tumors that are too small for us to see. And the same goes with neurosurgery as well. So systemic therapy is not only treating the tumors that we can see, but also any other small deposits of cancer that are there that we can't see yet that might actually show up on the next scan if we don't address them right now. Certainly, the other thing we're very interested in doing is not only treating the brain mets that are there, but preventing new ones from forming. Again, these are cancer cells that are starting somewhere else in the body and figuring out a way to travel to the brain. We'd like to prevent that from happening. And again, sort of the key part about systemic therapy that differentiates it from the radiation techniques you heard about and from surgery is that our systemic therapies are not only designed to treat the tumors in the brain, but the tumors at other sites in the body as well. And this is particularly important in melanoma, as a recent study that Dr. Ferguson and I have been working on reviewing the outcomes for melanoma patients diagnosed with brain metastases over the last 20 years shows that almost 95% of melanoma patients who are diagnosed with brain metastases also have tumors outside of the brain and the rest of the body at the same time. And so we really need to think about not only how we treat the brain, but how we treat the whole patient and the whole cancer. And that's why systemic therapy, again, becomes such an important component of the multidisciplinary management of melanoma patients with brain metastases. Now, this again is an area where we've had a lot of progress, and this is going to overlap a bit with some of the information you heard from Dr. Tabi before, but hopefully we'll sort of reinforce some of those key points. So where did we start from? So I joined the melanoma department here back in 2007. And back at that time, what we knew was that melanoma among all solid tumors probably has the highest risk of cancer spreading to the brain. Again, it's not the most common source of brain metastases. That's really lung cancer and breast cancer, but those cancers are much more common than melanoma. So where melanoma really stands out is being the disease that if you have melanoma, this is the cancer that has the highest risk of spreading to the brain. And so this has always been an important challenge for us to improving clinical outcomes. And as Dr. Tabi mentioned, this is a cancer where we often see patients with newly diagnosed stage 4 disease who have CNS involvement, up to 10 to 20 to 30%. And in our stage 4 patients, historically, when we've reviewed their outcomes, up to 50% of them develop brain metastases over the course of disease. And in the old days, when our standard treatments were chemotherapy and biochemotherapy, very often the first place that those treatments didn't work was the brain. We could see patients where the treatment was working in the rest of the body, but the tumors would really progress or escape in the brain. And so this has always been a really important issue for us. And again, before our current era, what we really used to treat melanoma was chemotherapy. And what was thought to be important was to get chemotherapies that could cross the blood-brain barrier. The blood-brain barrier is a defense system our body has set up to try to keep toxic things from getting into the brain, including many medicines. And so one of the things that's been a priority is to develop medicines that are able specifically to get into the brain to treat both brain tumors and brain metastases. And indeed, temozolomide is the primary chemotherapy still in use for patients with glioblastoma multiforme, the most common type of primary brain cancer. And for a long time, that was our standard treatment for melanoma brain metastases as well, because this is a chemotherapy. Patients would take the pills by mouth, and we knew the medicine could get into the brain. Unfortunately, it was not effective. And really, when we look back at patients with brain metastases treated with temozolomide, the chance that we would see significant tumor shrinkage was really in about the 5% range, sort of similar to how ineffective chemotherapy was at other sites in the body. And so we really didn't have many good tools to treat this very common problem. And as a result, as Dr. Tabi showed you, is that the diagnosis of a brain metastasis was associated with very poor outcomes. And so the very first paper I did when I was a fellow here at MD Anderson looked back at the outcomes of over 300 metastatic melanoma patients who've been diagnosed with brain metastases here at MD Anderson, and showed that on average, from the time they were diagnosed with brain mets, their average survival was only approximately 4 months. And this is skipping ahead to the last slide in a bit, but this is something where we think we've now quadrupled the outcomes. So a place that we've really made a lot of progress. So just to keep in mind, this is the past. That's not where we are right now, but it is where we started from. And so how did we make progress in the management of brain metastases from melanoma? And the first point is that melanoma is really a cancer that was transformed by breakthroughs in research. And I've highlighted here two of the leaders of this research, Dr. Andy Futrell, who's the chair of genomic medicine here at MD Anderson, and Dr. Jim Allison, the chair of immunology and the winner of the 2018 Nobel Prize in Medicine. And so Dr. Futrell is one of the scientists who really helped us to understand how often mutations happen in different cancers, and in particular helped to show that melanomas on average have more mutations than any other common tumor. And actually, in almost 50% of melanoma patients, we can find a mutation in the BRAF gene that gives us a specific target for us to actually inhibit the growth of these tumors. And so this discovery of the mutations that happen in melanoma, and particularly the BRAF mutations by Dr. Futrell, led to the development of new targeted therapies. So as opposed to the chemical warfare that chemotherapy is, specific targets that go in and hit the things that are abnormal in the cancer cells, but normal in the rest of the body. And while that's been transformative, it's actually really, again, Dr. Jim Allison, who really, with other researchers, opened up the world of immunotherapy by identifying the key regulators of the anti-cancer immune response, and particularly led to the development of new immune therapies and immune checkpoint inhibitors that have revolutionized not only melanoma, but really almost all different types of cancer. And so how has that work been translated into the clinic? So again, up till 2011, we actually never had a medicine that was shown to improve survival in patients with metastatic melanoma. Patients had an average survival of 6 to 8 months, and in a disease that often affects patients who are young and healthy, we're actually really interested in how many patients are long-term survivors, and that was really in the 5% range. And at that point, our only two approved therapies were dacarbazine, a chemotherapy with a response rate in the 5 to 10% range, and high-dose interleukin-2, which was really sort of the first immune therapy we used in melanoma, a treatment that could actually cure about 5% of melanoma patients, but had so many toxicities that it actually resulted in death in 1 to 2% of the patients because of its side effects. And so that's really where we stood up till 2011. But building upon the work of Dr. Futrell, Dr. Allison, and others, in the last 11 years, we've had 14 new treatments approved for patients with metastatic melanoma. And one of the keys to this is not a single one of them is chemotherapy. They're evenly divided between those immune therapies that work by boosting the body's immune system to recognize and fight cancer, and those targeted therapies that go in and attack the mutations that are present specifically in the cancer cells. And as a result of all of these new approvals, we've seen remarkable improvements in the outcomes for patients with stage 4 melanoma, such that we now think that the median survival has gone from 6 months to probably close to 3 years, and our long-term survival rate, we think, is now getting up to about 40%. And so really, again, a tremendous amount of progress in the last decade. Of course, though, still much work to be done. Now, one of the challenges we have for those of us who focus on improving outcomes in patients with brain metastases is sort of highlighted on this slide. And that is, and this is data that actually Dr. Tabi went back and calculated. And so if we look at the 14 phase 3 clinical trials that led to the approval of all those agents that I showed you on the last slide, not a single one of those patients had active brain metastases. And that's because historically, patients with brain metastases have been excluded from clinical trials. And this has been justified by concerns about could there be new side effects in patients with brain metastases? Would we not get same activity because the medicines don't get into the brain as well, and the overall poor prognosis of these patients? And again, this is something that not only we as investigators recognize as a huge problem, clearly to the patient advocate community who recognize this as a problem, and even the FDA has had meetings involving us and patients and companies and come out with formal declarations and guidance to pharmaceutical companies that patients with brain metastases need to be included in clinical trials. But I will say that this is a place where you as patients can still have real impact by helping us to advocate for you to overcome this barrier. And indeed, in melanoma, although those clinical trials did include patients with brain metastases, we subsequently have conducted clinical trials that have really demonstrated, after these drugs got FDA approved, that they are absolutely safe and effective, even when cancer has spread to the brain. So let's talk about some examples of that. And let's start off with immunotherapy, because that's been so impactful in this cancer. And our initial clinical trials started with single-agent immune therapies. Indeed, these were the first immune therapies that were approved for patients with metastatic melanoma, including ipilimumab, pembrolizumab, and nivolumab. And what we saw with each of those medicines as a single agent is that about 20% of patients who had asymptomatic brain metastases, i.e. brain metastases that were seen on MRIs but weren't causing any neurologic symptoms, weren't requiring the use of steroids to control that cerebral edema that Dr. Ferguson talked to you about. Each of these treatments achieved clinical responses in about 20% of patients. Now, what we did see in 2 of those trials that included patients who actually had symptoms and needed steroids is that that response rate dropped from 20% down to about 5%. Now, one of the important things is that in these clinical trials, for those patients who responded, almost all of those responses were very durable, i.e. lasting for more than 2 to 3 years, and probably are still ongoing. We don't know actually that those responses ended. We just haven't seen any updates from those studies. And so what we observed in these clinical trials, importantly, is that using these medications in patients with brain metastases, we observed no new side effects. These were just as safe in patients with brain metastases as in patients without brain metastases. As I mentioned, we had the proof of principle result that if we could get immunotherapy to work in the brain, not only again would we see tumors shrink, but we could see the same long-term responses that have been so transformative for our field of not just slowing the cancer down, but hopefully actually curing patients with metastatic melanoma. Now, we did again see these lower responses in patients who had symptomatic tumors or on steroids, and so often those patients were subsequently excluded from clinical trials. And although this again gave us much hope and optimism moving forward, we all recognized that we needed immunotherapy that would have much higher response rates than 20%. That simply isn't good enough. And so actually in 2017 at the ASCO annual meeting, we really had what in retrospect was a historic day. And that was a session that was held to talk about new clinical trial results for immunotherapy and targeted therapy in melanoma patients with brain metastases. And the immunotherapy presentations focused on combination immunotherapy with ipilimumab and nivolumab, which again was approved by the FDA in 2015. And so Dr. Tabi led the largest study, the Checkmate 204 study that included almost 100 patients with asymptomatic melanoma brain metastases and reported the highest response rate we'd ever seen for an immunotherapy in patients with brain metastases, almost 60%. And in particular showed in this initial trial results that those responses were not short, but at the time of the presentation, 90% of those responses were ongoing. And in that study, the one-year survival rate was now not 20%, it was 80%. And that presentation was followed by Georgina Long from the Melanoma Institute of Australia, who presented the ABC trial that compared that same ipi-nivo treatment with giving nivolumab alone, and showed again a response rate of almost 50% with ipi-nivo, and in that trial showed very clearly how much more effective ipi-nivo was than single-agent anti-PD-1. Importantly, both clinical trials showed that we again had a pretty high toxicity rate with ipi-nivo, but it wasn't any different than what we see in patients without brain metastases. And so really, almost immediately after that meeting, ipi-nivo became a standard of care option for many of us for patients with asymptomatic brain metastases. Now, we have learned much more about ipi-nivo for brain mets over time, and in particular, Dr. Tabi's Checkmate 204 study has taught us a couple of important lessons. And so first, we've now got longer and longer follow-up from those patients who had asymptomatic brain metastases, and he's shown now out to 3 years from the start of the treatment that almost 90% of those responses are still ongoing. So not only were we getting a high response rate, but they're durable, and importantly, every single patient who experienced shrinkage of their brain metastases also experienced shrinkage of tumors in other parts of the body. So he was seeing highly concordant responses both in the brain and in the rest of the body. Really remarkable results. Now, with the exciting results that they saw in patients with asymptomatic brain metastases, they also treated a small group of 18 patients with symptomatic brain metastases. And here, the response rate dropped from 50% back down to 20%. Now, for those 20%, those responses are very durable, but clearly, this is much lower than what we see in patients with asymptomatic disease. And so as we now work on how do we improve immunotherapy for patients with brain metastases, one of the key challenges is how do we improve outcomes specifically for patients with symptomatic brain metastases. And this is where we think not only do we need to look at combining other medications, but this is where there may be justification for combining these systemic therapies with radiation or with surgery to really result in much better outcomes. Now, in that same session at ASCO in 2017, I actually presented results for targeted therapy in patients with brain metastases. So again, almost 50% of melanoma patients have a BRAF V600 mutation present in their tumor. We now have 3 different FDA-approved medicine combinations that combine a BRAF inhibitor with a MEK inhibitor. And in the clinical trials that we had done for patients without brain metastases, we showed that these BRAF-MEK combination treatments have a very high response rate, 70 to 75%, and really over 90% of the patients, we can actually see the tumors at least stop growing. These responses on average last about a year, so much shorter than what we see with immunotherapy overall, although a subset of patients, about 20%, will actually still have responses that are 5 years or longer. Now, again, all of those initial trials excluded patients with brain metastases, and so I presented at that ASCO meeting the COMBI-MB study that took one of those approved BRAF-MET combinations, dabrafenib and trametinib, and evaluated it in patients who had brain metastases with a BRAF V600E mutation. At the top right, this is what we call a waterfall plot, and this shows what was the change in size that happened to the tumors when we gave them the treatment. So any line that goes up means that the tumors got bigger, and any line that goes down means that the tumors got smaller. So by our clinical trial criteria, we actually had a response rate of about 60%, just about as high or maybe slightly higher than ipi/nivo. But again, if you look at that waterfall plot, really in the end, almost 90% of patients, we at least got the tumors to slow down. This was effective even in patients who were on steroids or had symptoms, and these responses were very rapid in onset, and there were no new side effects. So all of that was very promising. So the initial upfront activity of the targeted therapy is very good for brain metastases. However, the part that surprised us and was unexpected was that the duration of the response in those brain tumors before they started growing again on average was about 6 months. And that was actually about half as long as what we had seen in previous trials in patients without brain metastases. And indeed, in this study, 50% of patients had tumors start to grow in the brain that had become resistant while their tumors in the body were still controlled. And so overall, we showed that targeted therapy was safe and had very high initial response rates in patients with brain metastases, even in patients on steroids, but that duration of response was really lacking. And so the targeted therapy key challenge is how do we improve the duration of response? And actually, just to give you a little more information about, well, what are we doing to tackle that? We've shown in multiple different clinical trials that we can measure for our BRAF inhibitors and our MEK inhibitors how well they're inhibiting this MAP kinase pathway by doing an immunohistochemistry test. When we come in and block the MAP kinase pathway, we see a dramatic decrease in phospho-ERK. And what we've seen in some of our clinical trials is if we look at these biopsies, we actually see a linear relationship between how much the pathway is blocked and how much the tumors are shrinking. The more we block the pathway, the more the tumors will shrink. And that's raised the question, or really the hypothesis, that maybe the reason the targeted therapy isn't working as well in the brain as it does in other sites is because maybe we're not blocking the pathway as effectively in the brain metastases as we do in the rest of the body. And so what are some strategies to overcome this? And these are actually now clinical trials that we're doing. One thing is can we just give higher doses of the BRAF and MEK inhibitors? And so we have a trial ongoing evaluating that here at MD Anderson. But there's one other strategy, and this is now borrowing from advances that have been made in patients with breast cancer and in lung cancer, where they had a similar problem with targeted therapies that would work really well outside the brain, but not as well inside the brain. And they took those first-generation inhibitors and then modified them to come up with second-generation inhibitors that are now designed to get across the blood-brain barrier, kind of like I talked about with temozolomide, but now with targeted therapies instead of with chemotherapies. And in breast cancer and lung cancer, that's been absolutely transformative, not only making treatments to the brain be more effective, but also reducing the risk of brain metastases. And so we now have clinical trials with BRAF and MEK inhibitors designed to cross the blood-brain barrier. Hussein, I see you raising your hand. Do you have a question? Maybe that's just
no, sorry, that's a mistake. That's a mistake. I apologize.
No problem. All right. So that's one strategy, is simply, is this a problem with the drugs not getting into the brain? But there is another possibility, and I think this gets to the overall question, how can we make further improvements in our treatments for patients with brain metastases? And that's to do focused research on brain mets, not to assume that they're the same as tumors growing anywhere else in the body. And so this is now research that several groups have done, but we were really one of the first groups to go back and look at tumors that had been resected from patients here at MD Anderson, and specifically looking at brain mets that have been resected, and then from those same patients, tumors from other sites like the lungs or the bones or the liver or the lymph nodes. And in the laboratory, we used many different approaches to compare within the same patient what was the same about their brain metastasis and their other tumors and what was different. And this was really the first time this had been done on a large scale and with many of our current technologies. And what we found was really quite striking. It showed that in a patient with metastatic melanoma to multiple different sites, the brain mets are very different from the tumors growing in other sites in the body. So immunologically, they have many less immune cells that are present. And so for something like anti-PD-1, where it's really important to have those immune cells present at the beginning, maybe this is why anti-PD-1 antibodies didn't have as high a response rate in the brain as they did elsewhere. We also saw two different molecular changes in the tumors. They had higher activation of what's called the PI3 kinase pathway and increased use and dependence on a different metabolic pathway called oxidative phosphorylation. And importantly, both of those pathways have been implicated very much in resistance to targeted therapy and also somewhat in resistance to immune therapy. And what was really neat in the laboratory is that when we started using inhibitors of that metabolic pathway of OXPHOS, we found that this treatment was actually more effective for the brain tumors than it was for tumors in the skin, tumors in the lymph node, or tumors in the lung. We actually were finding a specific dependency and vulnerability in the brain metastases. And so conceptually, a treatment that might actually specifically need to be tested in patients with brain mets, as opposed to those being the patients who would be excluded from the trials. The other sort of important finding was working with Jason Hughes, whose lab is next to mine, and he's the head of our brain tumor bank, a very good neuropathologist, is he did a similar analysis of brain metastases from multiple other tumor types, including lung cancer, breast cancer, and kidney cancer, and he found the exact same three findings we found in the melanoma brain mets in each of those other cancers. And so two new paradigms that come out of this is this idea that there, instead of excluding patients with brain mets from clinical trials, there may be some medicines where those are exactly the patients who actually will get benefit from them. And if we don't actually include those patients in trials, we may actually miss opportunities to improve outcomes. So not waiting for post-approval studies, but situations where those are the first patients who should be trusted with these medicines. The second idea is a sort of an interesting sort of concept, but maybe whenever a cancer cell gets to the brain, no matter whether it's a melanoma, a lung cancer, or a breast cancer, there may be certain changes that happen when the cancer cells get to the brain that make them vulnerable to certain types of treatments. And so while we normally have trials for melanoma patients or lung patients, or breast cancer patients, this supports the rationale that there may be treatments that work for brain metastases regardless of what type of tumor a patient has. And so just to close this up and sort of summarize our opening talks, I started with where were we back in 2010, and let's talk about where we are now. And so as you've heard, we have many new, more effective treatment options for patients with melanoma that has spread to the brain. Whole brain radiation therapy, which really didn't have much impact on tumors and can do severe damage to normal brain tissue, has largely been replaced by stereotactic radiosurgery and gamma knife radiation that are much more effective at controlling the tumors and do much less damage to normal brain tissue and have much less impact on neurocognitive function. And for systemic therapies, chemotherapy has been replaced by immune therapies and targeted therapies that not only have much higher response rates, but also work much longer and actually have much less side effects. And so with that, I mentioned way back in 2010, the median survival for patients with melanoma that had spread to the brain was down to about 4 months. And what we've seen over time is progressive improvements. And so shown to the right is a figure that Dr. Ferguson and I are, again, senior authors on a manuscript reporting sort of the improvements in outcomes. And this has been stepwise, but between 2014, for patients who are diagnosed with melanoma brain mets in that era, we now see that the median survival is now more than a year, out to almost 14 and a half months. And again, that represents a lot of improvement, but certainly not as much improvement as we would like to see. And so I think the other important idea here is that there's a real evolution in the paradigms for brain metastases. So here at MD Anderson, we and multiple other centers now have clinical trials specifically for patients with brain mets. Instead of excluding patients with brain mets from these studies, these are specifically designed for patients with brain metastases, something that we hope really becomes the standard at all cancer centers, but something that we believe in very strongly. In parallel, as I sort of showed you, there's also now increased amounts of focused research to really understand what's different about brain metastases, what are the different treatments we need to do for brain metastases. Don't assume that they're same as cancer that's growing everywhere else. And finally, what you'll hear about this afternoon is what's really important to taking all of that information and really helping patients to survive longer is the development of multidisciplinary brain metastasis centers, both to deliver the best care that we possibly can, but also to advance and accelerate research, both in the laboratory and the clinic, to build upon the advances we've made the last decade. So with that, again, this is work that's been supported by many different organizations, many different collaborators. And I would just again like to thank AIM again for the opportunity to talk with you today about the progress we've made, but also where we're trying to do better moving forward. So thank you very much.